I essentially use it for all my anesthesia cases where I think or suspect there is a tumor, a bladder cancer, or where I'm reevaluating a patient after they've had treatment of an aggressive bladder cancer, for instance, one with high grade but still non-muscle invasive. I want to know at the 3-month time point if I've been successful with my treatment. So I'll use blue light to look for those lesions that I might miss otherwise. So I think the management is going to change in a very positive way once we have the blue light available in the flexible setting. Just to be sure, it's not going to supplant the need and the use for the rigid scope, because we still need that during the times in the operating room where we're doing more instrumentation using the blue light, for instance, with resections, with more substantial biopsies and so forth. But what it will do is it will take some of the cases where, for instance, we're doing a 3-month follow-up, and it will transport them from the operating room where they're under anesthesia with a rigid scope to a more friendly office setting where we can do a relatively easy check like we do with white light, but this time with a higher degree of specificity for finding any recurrent lesions. So patients need to know that blue light is an option for them. And I think every patient should inquire whether their urologist is using blue light, and if so, whether they are an appropriate candidate for that. Certainly anyone with high-grade disease, anyone with a suspicious or positive cytology for which prior studies have not shown a particular lesion, really require blue light in order to settle the difference there. So I would hope that an educated patient population will in fact insist on using it under those circumstances. Another circumstance where I think it's important that patients need to know about blue light are for those cases where, despite everything that seemed to have been done correctly, they're having recurrence after recurrence. And the question, certainly in the patient's mind, is, well, are we missing something here? And I think with the blue light, we can certainly have a greater chance of being certain that we've done all that's physically possible to eliminate any sources of recurrent cancer. The small ones can be practically invisible under white light. So I've been using Cysview for about 7 years, and it has really substantially changed my practice because I have adopted it, having seen it work in so many cases for basically all of my anesthesia-related cases. In particular, I do a procedure called a restaging procedure at the first cystoscopy, basically 3 months after the initiation of therapy for high-grade disease. That includes the papillary high-grade as well as the carcinoma in situ. And we found when looking at our data from pre-blue light, we were missing 25% of all the cancers, even with cytology and white light. And it really was eye-opening to see that many of these were simply invisible lesions. And so as part of that regimen, I include blue light routinely in every patient that is at the 3-month point with an aggressive cancer. With the new development of the flexible scope, it will allow the possibility of basically doing surveillance on blue light, something that we've never really had the chance to do before. I think this will probably be for patients that are particularly high risk, who perhaps their urinary parameters that look for early signs of bladder cancer haven't normalized yet. And you'd rather get an earlier indication of a recurrence simply waiting for a visible lesion to manifest, especially if they've had blue light only visible lesions in the past. So these are people I would follow more closely. I'm not sure if I would do it with every cystoscopy, but maybe every other one. And there's also the concern that patients, they have read about the blue light. They want the most sensitive, specific tests they can have. And so I think we'll be driven a little bit by patient demand as well.